Thank you. Good afternoon or good evening. I'm a medical oncologist and epidemiologist. I'm a cancer doc. I'm trained in epidemiology. I look at what's happening in the population in terms of trends in cancer. I spend a great deal of time trying to figure out how to interpret data and looking at why there are differences and how we can improve medicine. Let me start out by, as we often do in medicine, presenting a case to you. Mr. Samuels, not his real name, was a 60-year-old white man who passed out while working. He was a contractor. He was taken to the University of Chicago Hospital in the fall of 1983. He was resuscitated in the emergency room and admitted to the internal medicine service. I, as a third-year medical student, was charged with taking care of him, along with some other doctors. In taking a history and physical, Mr. Samuels had had abdominal problems for more than 8 years. He knew he was sick. He had not sought health care. We ultimately diagnosed him as having metastatic colon cancer. He lived for another 3 months, and then he died. And his wife and adult children invited me to come to his funeral. Hence, I learned a few things. I learned about the honor and privilege of being a doctor and a healthcare provider. I also learned a little bit about health disparities, how we in medicine can do better. In terms of health disparities, one of the reasons why I came to Emory is so that I could work with some marvelous people in the School of Public Health and the School of Medicine to help to define what health disparities are and how we can better serve the people of the United States and indeed people of the world and do better in terms of taking care of medicine. Much of what I'm about is not finding a new drug or a new treatment, but making sure that people actually can enjoy the drugs and treatments that we already have. So a little bit in terms of looking at healthcare in the United States and are we leaving people behind? First, I want to note that in the year 2016, the United States spent $3.3 trillion on healthcare. That's $3.3 trillion, not $3.3 billion. $3.3 trillion is a large amount of money. All right? These are the largest economies in the world. If American medicine were a country, it would be the 5th largest economy in the world. We spent more money on healthcare than was spent on everything in the United Kingdom, and we came close to the economy of Germany in 2016. $3.3 trillion. This slide actually illustrates life expectancy in a number of Western European countries. The line that you see going vertically to the right of the screen, that's the average life expectancy in Western Europe, in the United States, North America, Japan. The dots are cost, on the y-axis are cost per person. You see the red dot on top. The United States spends $9,000 to $10,000 per man, woman, and child per year on health care. It's the most expensive country in the world in terms of health care. But we don't have the greatest life expectancy. We don't even get to the average among Western European countries. Warren Buffett is fond of saying, cost is what you pay, value is what you get. Ladies and gentlemen, I have shown you that we spend a lot on health care, but we do not get value. The United States healthcare system is incredibly inefficient. We focus so much on diagnosis and treatment and spend very little time focusing on prevention of care. It's estimated that 30 to 40% of all the money spent on healthcare in the United States is waste. We could do better. People are dying needlessly because we are not working in a very efficient system for healthcare. Let me give you some examples of disparities. These are cancer disparities. I'm a cancer doctor. The age-adjusted death rate for cancer in the state of Utah is in the last year for which there's data, 2015, 125 people died for every 100,000 people in the population. The equivalent in Kentucky was 195. 195 versus 125. That's a disparity. Let's look at colorectal cancer, the disease Mr. Samuels died of in 1983. The American Cancer Society this year estimates 145,600 will be diagnosed, about 51,000 will die. There has been a 50% decrease in the age-adjusted mortality rate for colorectal cancer since 1980. That's a really good thing. That means your average 60-year-old man or woman today, the risk of dying of colorectal cancer is about half of what it was for the average 60-year-old man or woman in the United States in 1980. That's a really good thing. But let's talk about the disparities. This map shows the decline by state. In the upper Northeast, the dark blue states, we have amazing declines. We have a 63% decrease in age-adjusted mortality from colorectal cancer in Massachusetts from 1980 to 2015. It's 13% in Mississippi. Health disparities is Massachusetts versus Mississippi when you're looking at colorectal cancer. Look at the purple there. We need to focus on prevention in the United States. We focus so much on diagnosis and treatment and then don't do that very well. We need to design communities to encourage a healthier lifestyle. We need to encourage a lifestyle where people walk. We need to encourage people not to smoke. We need to have an environment where it's difficult for people to actually smoke. It's amazing. We actually have good science to show that when it's hard for people to smoke, guess what? People don't smoke and people don't start smoking. We need to increase access to better food choices. You're going to hear more about that in a little bit. We need to increase access to high-quality care. Now, one of the things that we did last year, my epidemiologic group, was try to quantify cancer health disparities in the United States. It's estimated that 607,000 Americans are going to die from cancer this year. We actually are able to estimate that 152,000 of those Americans would not die if all had adequate preventive, diagnostic, and therapeutic care. 1 in 4 deaths would not occur if we just logistically were able to get every American what every American ought to get. Now, ladies and gentlemen, in 2009, I went away for about 9 months as a reservist. I was the doc on the USS Macon Island during the surge in Iraq. I spent some time in the Pacific and Indian Ocean. The thought of Otis Brawley and 1,800 sailors and Marines on one ship is a thought in itself. Average age 22. On that ship, as in much of the military, we had this saying, "We are Americans, we leave no one behind." I came back to my hospital in Atlanta, and I walk around and I say, "We are Americans and we leave a lot of people behind." 1 in 4 cancer deaths is preventable if we simply got what we already know every human should get: prevention, diagnostic, and therapeutic to every American. By the way, the majority of those preventable deaths are like Mr. Samuels. Mr. Samuels did not have insurance, and he did not have the ability to go get the care that he knew that he needed to get for the 8 years that he had those symptoms. The majority of those people who are disparate are white Americans. Yes, there's a huge black-white disparity in the United States, but the majority of the people who suffer and die because of disparities in America are white. The majority are residents of the southern United States, those purple states I showed you in that slide. The majority are middle class and blue collar. They are the middle class who don't have access or the ability to utilize good health care. The issues of disparities are about race, but they're also about socioeconomics. They're also about region of the country. We can do better. I ask you to take a little personal responsibility about your own health. Everybody should try to walk 40 or do something aerobic for about 45 minutes 4 times a week. It can be walking, it can be running, it can be the elliptical. I've seen the president of the university at the gym a few times. Everybody should try to eat 5 to 9 servings of fruits and vegetables every day. We should all avoid smoking and other high-risk behaviors. We should pay attention to the healthcare debate, and we should care about other Americans. We should try to leave no one behind. Let's work together to make this a much more efficient system. We're spending so much money on healthcare. If we could just be a little bit more efficient, we could save a lot more lives. Now you've had a little idea of what I do as a Bloomberg Distinguished Professor, and what coming to Hopkins has allowed me to do is work with some amazing young people in the School of Public Health who are interested in studying these things, some amazing scientists in the School of Medicine who are also interested in developing treatments and getting these treatments to folks. And I thank you.
Yeah.
Thank you.